Welcome to Magazika. Today we have the honor of speaking with Professor Steven Narod, a leading voice in breast cancer research. For over 3 decades, Professor Narod has dedicated his career to understanding and combining this disease. His work at the University of Toronto's Institute of Medical Science has challenged conventional wisdom and offered new perspectives on breast cancer. His recent book, A Fair Trial, is already sparking important conversation. We are here to explore his insights, his journey, and what they mean all for us. Professor Narod, welcome to Magazika.
Thank you for inviting me.
You have dedicated, as we have said in the introduction, you have dedicated 30 years, 3 decades of your research in breast cancer. That's a remarkable commitment. So, what initially sparked your interest in this field, and what keeps you driven after so many years?
Well, that's a good question. I started my training in mathematics at the University of British Columbia back in
Yeah, I've seen that. Yeah.
1971, and then I went into medical school in 1975 and graduated at a relatively young age, 24, back in 1979. And I was quite interested in the mathematics and given my background of how research and science worked. So I studied public health as my specialty in Ottawa. And then I moved on to the University of Toronto to do a little bit of research with Dr. Tony Miller, who is an expert in cancer epidemiology. And together we worked on the breast cancer screening study. Started in 1983, and we published it in 2014. That was 30 years of work together. I got interested in sort of the genetics of cancer from the point of view of did chemicals in the environment, what we call mutagens or chemicals that make mutations in the DNA, how much did they contribute to the cancer burden in Canada? So I worked a little bit at with the government of Canada. And as I learned about genetics, I learned about the role of mutations in DNA damage, I got interested in the possibility that there were genes out there which are inherited that were not induced by exposures, but they were inherited from mother to daughter, and that the technology at the time would allow us to find these genes and use that information for people at high risk. So I did study genetics at Sick Children's Hospital in 1985. And then from then on, I went to the International Agency for Research in Cancer for 2 years. That was in Lyon, France. And my project at that time was fortuitously how to find a breast cancer gene. So that's my first start. I've been doing on that since 1987. I was very fortunate to have a great team working with Gilbert Lenoir and Jean Fontan in France. And we were very fortunate to have a colleague who lived in Omaha, Nebraska, a well-known guy named Henry Lynch. And Henry Lynch had collected a lot of families over the years and was forward-thinking and collected blood samples on them. So he gave us all these pedigrees, these family trees of women with breast cancer in many cases, and we got blood samples on them. And they were worked using the laboratory. We were trying to find which marker, which part of which chromosome went along with the breast cancer, followed the risk of cancer through the families. My job was to do the statistical analysis based on my mathematics degree, and computers were just getting started. So we worked on that, we and other groups, and eventually in 1994, we discovered the breast cancer BRCA1 gene. 1995, discovered the BRCA2 gene. Now, those were the early days, but my training as an epidemiologist and mathematician, I right away got involved in the questions of, well, what are the risk factors? What can we do? How high is the risk? The risk is high for BRCA1 and 2. The risk of breast cancer is about 80% over lifetime. But can we reduce this? We can reduce this by maybe knowing which risk factors contribute. We can reduce this by better screening, perhaps. We could reduce this perhaps by an anti-cancer pill. We could reduce this perhaps by preventive surgery. So I started collecting patients in 1995 and continuing to the present, have about 18,000 women throughout the world that we follow that have a BRCA1 or BRCA2 mutation. We ask them questions every couple of years. What hormones are they taking? What screening have they had? What surgery have they had? And over the years, we've been able to really get a handle, a good idea of what we can do to reduce that cancer risk from 80% back closer to the population risk. That's been a very productive part of my career. I think that's what I'm best known for, although I've been branching out into many other areas of breast and ovarian and prostate cancer as well.
Yeah, no, that's a very fascinating journey. Like you encapsulated it in a very nice way. Let's come to your book, A Fair Trial: The Foundations of Breast Cancer 2024. I read that version. So far from my reading, I understood it challenges some long-held beliefs about breast cancer. For our readers who might not be an expert in the field and mostly who are from non-medical background, could you explain one or two key concepts from your book in a way that's easy to grasp?
Well, I hope it's easy to grasp. It's
Yeah.
certainly challenging for the medical establishment, but I hope I can explain it for people who are not necessarily specialists. It comes from, really working for 25 years, and some of the observations that I observed in my research seemed a little bit paradoxical, seemed to be against the conventional view of breast cancer. First of all, when we did a study on breast cancer screening in Canada, which has been with Tony Miller from 1983 to 2014, we did not find that annual breast cancer screening really prevented mortality. We found cancers, people that we found the cancers then had a better survival, but overall, roughly the same number of deaths in the women who went for mammography and those who didn't. And that sort of, was questioned and whether we did it properly, but it always stuck with me. There would be why would mammography not be a benefit as predicted? And then a second study we did on early forms of breast cancer showed, really surprisingly, that we could prevent breast cancer in many women without preventing death. Now, this is not all women. For example, jumping to 2024, our biggest and probably the most notable publication in that area was on the area of second breast cancer. So if you get breast cancer in your left breast, your chance of getting breast cancer in your right breast is about 10% over 20 years.
Oh.
Now, if you get the breast cancer, the second breast cancer in your right breast, your chance of dying of breast cancer goes up from about 11% to 18%. So clearly, there's a high risk of second breast cancer, and clearly getting a second breast cancer is not favorable for your outcome. But then we showed that many women who had both breasts removed, what we call bilateral mastectomy, reduced the risk of getting the breast cancer almost entirely. The women with the bilateral mastectomy didn't get a second breast cancer compared to the women who only had one breast removed. And we could prevent it very successfully. And many women chose to have bilateral mastectomies to prevent the second cancer. But surprisingly, it didn't have any effect on mortality. So even though getting a second breast cancer increased the chance of dying, preventing it didn't reduce it. And that was not that's similar to what was found back in the 1980s by Bernard Fisher, that if you had breast cancer in your left breast, and then you got a recurrence in the left breast years later, your risk of dying went up.
Oh.
But preventing it didn't increase your chance of survival. That was very surprising, and but that led to the concept of having a lumpectomy. So what's a lumpectomy? Lumpectomy is just removing the breast cancer, leaving the breast behind. Prior to that, women would get a mastectomy, which would remove the entire breast.
Entire breast, yeah.
Right. So we found, and Bernard Fisher found, that preventing the lumpectomy, about 15 or 20% of those women would get a recurrence in the same breast. And when they got a recurrence in the same breast, the risk of dying went up considerably.
Yeah.
But preventing the breast cancer through mastectomy had no impact on survival. That's why we do lumpectomy. We do lumpectomies, we tell the women, well, you're at increased risk of a recurrence, but it won't, it's not necessary to have a mastectomy because mastectomy doesn't reduce your chance of dying.
Mm.
Well, these were two observations which seem kind of symmetrical. You can get a new breast cancer in the same breast, you get a new breast cancer in the opposite breast. It really increases your chance of dying of breast cancer, but doesn't preventing it doesn't reduce your chance of dying of breast cancer.
Yeah.
That struck me as very similar to the idea of mammography. Well, if getting cancers when they're small is beneficial, then why would it be better than preventing it altogether? Now think of it like that. I can prevent the cancer altogether by the mastectomy or the bilateral mastectomy, but I don't reduce the mortality. So why would it be better to have screening? Anyways, this is a, if you want to go into it, I'm happy to read the book A Fair Trial.
Okay.
Now, for example, we see that women after breast cancer will have mammographies annually, just to check that they don't have a recurrence. But we've shown that preventing it doesn't reduce your chance of dying, preventing the recurrence. So why would finding it early improve it? So these are controversial because, mammography women are willing to have them. They wish to have them just to know that they're doing well. Recently, there was a paper published in the Lancet that said if you did the mammography every 3 years after breast cancer, was no better than doing it, was no worse than doing it every year. So they compared women who got breast cancer mammography every 3 years after the diagnosis to those that got it every year, and the survival was the same, which led me to question whether it's beneficial at all. There's never been a study yet to date which really shows that screening mammography after breast cancer reduces the chance of dying. There's a whole lot of observations that I really, I could go on and on, but I would really suggest people that are interested get a hold of the book A Fair Trial. I could be wrong, there's nothing in science that's fact. There's nothing in science that cannot be challenged. There's nothing in science that cannot be replaced by better and more recent and more insightful doctrine and more data. But, I do think it's worth having a look and seeing whether, people agree with me, or that if someone has a really good way to show that I'm wrong, I'd be more than grateful.
Yeah.
I think it's important to take up the challenge of these questions, whether we're really on the right track thinking of breast cancer. The breast cancer starts out in the breast, and certainly those are cancers, and they look like cancers, and we remove them. But when you die of breast cancer, you die because the breast cancer has spread.
Right.
All women who die of breast cancer, this cancer will have spread to the lung, the liver, the brain, or the bones. And that ultimately is what we want to prevent death. That's well known. So there's breast cancer within the breast and breast cancer in the metastatic or the organs. I just propose that these are two different entities, maybe have two different processes, maybe the natural history is not quite as we think. The conventional model says that breast cancer begins in the breast and then spreads. Therefore, if you remove it, you'll prevent the cancer from spreading and you reduce mortality. My model says they both happen independently at the same or different times, and the cancer may spread to the distant organs before it's prevented in the breast. Well, certainly women who succumb to breast cancer, this is really the take-home message of how we treat breast cancer patients in 2025. We can remove the breast cancer, and those women, we can remove it entirely. But those women still, 10 or 20% of them will die of breast cancer. How is that? Well, those women, the breast cancer had already spread to those organs before the cancer was removed from the breast. So for those poor, unfortunate women, they had metastatic spread at the time of diagnosis, and that was ultimately the cause of their death.
Yeah, when I was reading the book, in the part 4 of your book, I guess, so far I remember, it is called Dormancy and Activation. So how long it is dormant and when it will be activated, like it will be visible. So whenever we talk about a breast cancer patient, sometimes this between the time between dormancy and activation, there's a thing, in my understanding, there is an early detection, that how I can early detect a breast cancer inside me. So for this topic is kind of a concerning, because how do we go through that? How do we pick up that checkpoints that yes, I should go for a screening and everything? So how that impacted your research, or what are the guidelines you can give our readers, that what are the steps we can take for this, for a successful early detection?
Well, I think when I speak of tumor dormancy in that chapter, I really speak of the cancers that have already, the cancer cells that have left the breast and entered the metastatic setting, whether
Mm.
in the lung, the brain, the bone.
Yeah.
Now, what's interesting, what we refer to dormancy, is the time between the diagnosis of breast cancer and the time of recurrence. And that can be over 20 years. Now,
Oh,
why
wow.
is it? I mean, for example, one of the very surprising things that we found was that for women with low risk breast cancers, women with ER positive, small, well differentiated breast cancer, they can recur over their lifetime. And this amazing statistic is for a woman like that, the chance of recurring in the year 2 after diagnosis is the same as the chance of recurring in year 18. So, I
Mm.
mean, that's pretty surprising. And we can predict with pretty good accuracy what is the chance that the breast cancer will recur, but we're very poor at predicting when it will recur. Now, what's quite interesting about this, really, there are two kinds of breast cancer, main kinds. One, let's say we call triple negative breast cancer, ER negative, PR negative, HER2 negative, and one is ER positive breast cancer. Rebecca Dent and I wrote a paper back in 2007, which is actually the most highly cited breast cancer paper ever written in Canada, with over
Wow.
5,000 citations,
Fantastic.
where we clarified the different times of recurrence in triple negative breast cancers and ER positive breast cancers. And we showed that the triple negative breast cancers tend to recur in the second year. And
Mm.
by 6 years, they didn't recur. So if you were 6 years out from a diagnosis of triple negative breast cancer, you were very unlikely to recur thereafter. Whereas if you had an ER positive breast cancer, the risk of recurrence was at least for 20 years. Why the difference? Well, I claim it's, propose it, think it's due to tumor dormancy, that those
Mm.
cancer cells that are ER positive remain in a silent state, a sleeping state, what we call a dormant state. It can be for 1 year, it can be for 2 years, but it can be for 20 years. The triple negative cancers, they don't have that characteristic, and so they will recur relatively quickly,
Right.
whereas the dormant cancers can return at any time. Now, how do we predict it? There's blood tests now that are very good at predicting which people have dormant cancer cells. We have ctDNA. The scientific has really advanced in the past 3 years, where we have very good tests now, commercial genetic tests that look at the blood and can tell whether the cancer is still in your body or whether it's gone away. And if you get a
Oh.
positive test, you're very likely to recur. If you have a negative test, you're less likely to recur. The controversy there, and still what's outstanding, is what do we do when we get a positive test? There haven't been any studies yet that show that having a positive test early, we can intercept it and prevent the recurrence. So that's where we are in the state. I'm really optimistic that we'll be able to do so. But I do raise the point that, my patients will ask me in 2025 whether they should have these tests, which are not necessarily paid for by the government. And I say, well, that's really up to you, but you have to remember that if you have a positive test, you're going to be given a message that your chance of recurrence is very high, and yet we don't have a proven therapy that we can use to intervene at this time. It's
Oh.
important you'll get information that's quite accurate and valid, but maybe it's better to wait, because I don't want to tell you that, your cancer is likely to come back, and I don't really have something to do at this point to prevent that. But I'm optimistic that over the next 5 years, we'll do studies, whether it's new chemotherapy or whether conventional chemotherapy be given at the time of a positive blood test will prevent the cancer from progressing. And there's a lot of scientific work in this area. But I think it's interesting that the dormancy is one of my areas of study. I looked at it from a statistical point of view. I haven't really looked at it as a biologist, but person who studies cells. But that work is going. We do have a study ongoing, though, looking at if we can predict with certain factors what would cause a cancer to recur.
Oh.
My basic premise was that it was chance. But before I just say it's chance, I want to rule out any possibility that there are actual predictors of recurrence. Things like, it's been shown that things like having other disease like a myocardial infarction can accelerate the cancer from coming back. There's evidence that aspirin and vitamin D can be effective in reducing the chance of coming back. We certainly have drugs like tamoxifen. Tamoxifen primarily works by extending the time of dormancy. It does kill some cells, but it also kills them leaves them in a quiet state. When you take tamoxifen, the chance of the cancer coming back is reduced. Once you stop, I propose that the cancer risk comes higher. Fortunately, tamoxifen is a drug take every day, and it does have side effects. There's still quite a controversy these are given for women with estrogen receptor positive cancers. There's still some debate whether you should give it for 5 years, for 7 years, or for 10 years. It does seem to have a beneficial effect 10 years over 5 years, but it's a side effects of a drug and something we don't want to give to people for any longer than there's a benefit that's noticeable.
So many questions that I had some follow-up questions. You have already answered that. But so far, we were hearing about the research that you are doing. Research, specifically the type of research that you do, data-based and statistics-based. And it's so many times it's longitudinal studies and everything. These are very long and tedious for a layman like us. How do you keep yourself motivated in the process?
That's a really good question. I mean, some of, the breast cancer study that I talked about with the carriers, I started that in 1995. Some of the patients that have been enrolled in 1995 are still doing well. 30 years later, they still fill in their questionnaires. Once in a while, I get the pleasure to talk to them. And many are doing well, and they're grateful, and that really motivates me. The breast cancer screening study that I did with Dr. Miller, we started it in 1983 and published it in 2014. And every patient in that study was followed for 30 years to look at the outcome of mammography. Our current study, now we're looking at mostly a lot of studies on treatment of breast cancer, both in young women and in women with mutations. So I've really started up in the last 5 years, a pretty intensive study of looking at the various treatment options available to women with mutations in BRCA1, BRCA2, PALB2 with breast cancer to see if, we did start on prevention. Now we're looking at the optimum treatment. And many of those patients have been followed for many years. But we also have a technique, retrospective, where we go back and review the charts of people diagnosed 10 or 15 years in the past, and then ask what happened to them. What was the outcome? We have a lot of help now from, the Canadian Cancer Society and Canadian Ontario, that they record information. I think it's really important that we have these kind of databases that, that acquire information from people with cancer so that researchers like me or researchers, my students, the next generation, can interrogate those databases and ask, well, this patient had such and such, what was the eventual outcome? And I've been blessed to work with colleagues Mohammed Akbari, Joanne Katsopoulos, David Lim, Vasily Giannakis, Kelly Metcalf, here all at Women's College Hospital, who have really jumped on and helped along with the way. And they've really, they've all been here for pretty much 20 years. So it's really been a team effort, although I'm happy to be here but I'm really representing a larger group of research scientists. But we do find the more data that's collected through government sources, the more we're able to achieve. Many of our key papers are actually done on American data that was very well collected by, they call the SEER registry, which is an American database, which covers about half the breast cancer cases in the country. And we actually collected data on close to 1 million women with breast cancer. I didn't collect the data that was collected systematically through arms of the US government, but it's available to Canadian researchers. And we've published maybe a dozen papers using that database, which have been highly informative and highly productive. So really, I encourage, the government on Ontario and researchers both to get training in the use of these epidemiological tools to inquire about databases that are already existing. But sometimes the questions we ask are much more detailed, and we can't use an existing database. We have to go to the patient themselves. Like if we want to know about how long they did breastfeeding, how long they took hormone replacement therapy, how long they got oral contraceptives at MRIs, those studies, which are, more closely defined, we have to ask the patient themselves. So that's what we've been doing, both types of studies, and we're ongoing. I have the pleasure of working with Mei-Lin Kwan and a lot of colleagues. We're doing that for 1,500 women with breast cancer diagnosed under the age of 40.
Oh.
Now, these women, are unfortunate they get breast cancer at an early age. We'd like to see what we can do to intercept, make sure that they survive. And so that's a Canadian effort that we've been running for about 5 years, and now the data is quite mature. But that study, we asked them about their breast cancer, we reviewed their medical records, we got blood, we did genetic testing, we're doing a lot of things. So that's a very comprehensive study. So there are all different ways of doing it. I've been fortunate enough to be involved in all three. What keeps me motivated? Well, I'll tell you, the answers aren't out yet. I mean, I've been studying, the young women study we started and we finished the data collection, but I wouldn't wish to, stop my part in it, my participation now. I want to see how it turns out. With all the studies, the chance that we're going to get a good answer in the next 5 years keeps me going. That's my major motivation. And also, we like to think that we can help these patients through our efforts. And the other one is I'm really excited, I hope that my model of breast cancer, which I describe in a fair trial, gets a little bit, more out there, more information, more, discussion among the leaders in the cancer field and among the patients. So there's always hope that we're going to do better. I think there's lots of progress. We've seen particularly progress in some of these tests, which we can use to define your risk. We've got progress in tests that we can do on the blood to see if you're likely to recur. And there's been a lot of new involvement, new chemotherapies that are effective for women with mutations, for women without mutations. So there's a lot to go.
Yeah, a lot to go. And in your book, I'm seeing this in chapter 15, that you said the mammogram debate continues. So that means with your huge experience in the field, and as there are some, you said that mammogram debate continues and like that. So what are some most promising areas of breast cancer research now? You have mentioned some of the research tracks, all three of the research tracks that you were involved in. According to you, what are the most promising areas of breast cancer research right now, and what gives you hope for the future?
Well, I think a lot of it, most of the progress we've made over the past 10, 15 years, the reduction in breast cancer mortality has come from expanding the treatment, particularly the chemotherapy. There are new drugs out there, some of them, against estrogen receptor positive breast cancer, some against estrogen receptor negative breast cancer, that have made a difference. And generally, most of these drugs, this incremental benefit on mortality is pretty small. But when you add them up together and personalize the treatment and do different tests on the tumor, on the blood, we can find a better way of treating the patient. So up till now, I would say most of our progress has been made in the chemotherapy world. Certainly, tamoxifen was introduced in the 1980s and it's been very beneficial, and there have been some advances as well. I think, I do think understanding better of the natural history of breast cancer, I would propose that, I want to find ways of experimenting to see if I can actually prove my hypothesis and find a way that directing the chemotherapy towards the cells that have metastasized, not necessarily to the cancer cells within the breast. I think once we understand and have a better way of assessing the burden of chemotherapy, of breast cancer, one of the interesting things about it, you have to remember, is that the chemotherapy reduces the risk of dying by 1/3.
Yeah.
If we have 100 people with breast cancer, mixed stage breast cancer, intermediate stage breast cancer, we would expect 20 of those women to die of breast cancer within the next 10 or 15 years. Now, if we give them chemotherapy, we can reduce that number of 20 down to about 14. So we give 100 women chemotherapy to prevent 6 deaths.
Oh.
Now, every medical oncologist in Canada would say that's a fair trade-off. We're going to reduce your chance of dying from 20% to 14%. We're going to give you the chemotherapy. There's side effects, of course. And why is that? Because we can't pull out the 20 that have the probability of dying. 80% of those women, of the 100 women, will not die if they don't get chemotherapy. The cancer hasn't spread, and it has no ability to spread. It's after it's been removed. So why do we give those 80 women chemotherapy that are not at risk of dying? Because we can't identify them. If we could identify the 20 that would have a chance of dying and just live in the chemotherapy, we could de-escalate chemotherapy to 80% of the patients. That's a big challenge, and I think there's a ton of research going on now which has precisely that goal, by looking at the cancer themselves, by looking at the blood, to de-escalate chemotherapy, which is a wonderful goal, reducing the number of women who require chemotherapy. Nevertheless, just by reducing the number of chemotherapies, we won't reduce the number of deaths. We'll just remove a lot of side effects from a lot of women, 80 women who would get chemotherapy, many of whom would get side effects. I think it's a big improvement, but it's not one likely to reduce the number of deaths. To remove the number of deaths, we probably need to better target the cells, have a better understanding how each cancer is personalized, both from the point of view of the woman herself and the cancer that's in the metastatic niche, and the cancers in the breast. I think we've gone a little too far in the assumption that you look to the cancer cells within the breast as an outcome, whether you can prevent, people talk about preventing recurrence, preventing contralateral breast cancer as being a really valid outcome. I think it's wonderful to do so. We don't want women to get a recurrence, but preventing the recurrence in the breast has no impact on whether they die. You have to prevent the cancers from metastasizing in the first place or killing them once they've metastasized. The difficulty of preventing the cancers metastasizing in the first place is you have to do the intervention before the cancer is diagnosed. And that's quite a challenge. Once the cancer is diagnosed, it either will have metastasized or will not. After the cancer is diagnosed, it doesn't metastasize because you remove it. So that's quite a lot to quite a
No, it's fascinating.
maybe won't be so welcome, but
No, it's fascinating. It's fascinating to hear from a person who knows exactly what he's talking about. A huge
well, I
amount.
like to think so, but there's certainly other opinions out there, and I wouldn't want to say that you shouldn't approach other people to see whether there are people who disagree and reason.
No, it's obviously. But I'm a big fan of, I do not know if you have come across the book or not. I'm a big fan of Thomas Kuhn, The Structure of Scientific Revolution. I'm a big fan of
Yeah,
that. So he says
not
that,
often.
yeah, he says that every scientific progression happens on a paradigm shift. After Newtonian mechanics, Einstein's mechanics came into picture, and then it will go on to another paradigm shift and everything. So
To quantum mechanics.
yes, through quantum mechanics. So it was a big paradigm shift that how we see the world from a scientific perspective, from Newtonian mechanics to quantum mechanics. So, Professor, you have made a great impact to many people's life. This is our last question. Not a question; it is a conversation topic. I'm in no position to question you, so I'm just popping up the conversation. So, you have made a great impact of a lot of lives through your research, through your insights that you have provided over the years, and the model that you have presented in Fair Trial. Fascinating. At the end of the book, you have attached 10 questions about breast cancer. I encourage almost all the readers to read it. It's a fascinating list of questions. What do you hope your legacy will be? How do you see yourself? Or what message would you like our readers to leave with?
Well, that's a good question. Certainly, we have some of the practical studies. We'd like our studies to be able to have a direct impact on the lives of women with breast cancer. We have shown in the last year that bilateral mastectomy, I mean, that MRI, magnetic resonance imaging, was very effective in reducing deaths in BRCA1 carriers. We now are doing a lot of work. I'm giving you a heads up. I think one of the most important questions we can ask, and one of that's still unanswered, is whether we can give women with high risk of breast cancer or with breast cancer hormone replacement therapy. Many of my patients undergo preventive oophorectomy, having removed their ovaries at a relatively young age, in the 30s and the 40s. And it's often people shy away from giving them estrogen or hormone replacement therapy, feeling that might increase the chance of the breast cancer coming back. We're putting a lot of effort now into looking to whether that's true or not. I would love to be
Okay,
able.
excuse me. I'll just sorry. I'll just interject in one way. At the very beginning of the interview, you have said you are involved. Your research is involving 4 groups of women. Is it related to that as well? Can you please a bit extend on
Yes,
that?
it's related to both young women and women with BRCA1 mutations. You know, it's been shown since 1896,
Hmm.
not in a paper written by Beats in the United Kingdom, that oophorectomy, removing the source of hormones, can be a therapeutic in women with breast cancer, young women. Was embraced. Now we have drugs that can do the same thing, that can put your ovaries to sleep. But we do find in the BRCA1 carriers, and this was published last year, that taking their ovaries out at a young age has a remarkable impact on reducing the risk of dying, both from ovarian cancer and breast cancer. That's unequivocal, but the question we want to raise now, we want to be able to give them hormone replacement therapy to maintain a good quality of life. And we're really putting a lot of effort into that now. We're using several of our studies, in particular the BRCA1 carrier studies, and we're investigating that now. I can't give you the routes now, but I would just say I'm optimistic that we'll have something really important. And when we
Fantastic.
talk about quality of life, you know, there are many issues for a breast cancer patient. The side effects of the treatment, which we want to reduce. We want to reduce the side effects by treating the side effects appropriately. We want to reduce the side effects by avoiding giving chemotherapy to those women who may not benefit. We want to be able to maintain a quality of life by giving hormones to those who go through menopause, either by the chemotherapy or by the oophorectomy. And we want to maintain the quality of life by giving good body image, by proper surgery and reconstructive surgery. So there's a lot out there. So, you know, we really think now about the notion of patient-informed consent. The patient may, now in 2025, the patient has a lot of impact, a lot of input into the decisions that are made. Not so much for chemotherapy, definitely for the type of surgery, it's their choice. Whether they wish to go through radiotherapy, they can have a choice. Whether they wish to take tamoxifen, they do have a choice. Whether they wish to have screening, they have a choice. So there's a lot more. The world has advanced in the setting, certainly in Toronto and Canada, that we like to engage the patient in the discussion regarding particular therapies and give her the information about which ones are likely to benefit, how large the benefit is, and what side effects you might experience.
Oh, yeah. So, yeah, you have talked a lot about this patient perspective in one of the chapters. That one total dedicated chapter is from the patient perspective. Yeah,
I think that's fascinating. You know, certainly people, you know, the mainstream scientists and some of the people I've recently met at some of the meetings, you know, say, well, we present the information to the patient and the patient makes the decision, which I think is fair and I think is appropriate, but it varies a lot. Sometimes the patients, you know, don't look at it the same way as we do. For example, in the terms of screening, the doctor wants to do screening in order to detect the cancer early in order to prevent death. A lot of the patient's wish is primarily to be told she doesn't have cancer and she's going to be fine. And this is one of my perspectives, and we've interviewed patients and found that even if the intervention doesn't promise improvement in their life expectancies, most of the patients want to be told, you don't have cancer, you can go home. So that's why many of us continue to do some of these tests, mammography after screening, for reassurance of the patients, and that's very helpful. But reassurance is not, the primary goal. The primary goal is to prevent death. Reassurance is definitely part of quality of life. Much of quality of life, talks about side effects, but don't underestimate the importance of anxiety, depression as a part of quality of life. And we found, for example, in the patient perspective, quite surprisingly, that those patients who were diagnosed with very early forms of breast cancer, who had a chance of dying at 5% or less, really fortunate, early to, and the patients with a higher chance of dying, 20 or 30%, experience the same levels of anxiety.
And finally,
That was a striking finding for me. In fact,
yeah.
it made me think.
And for this huge contribution to the field and everything, so congratulate again of your inductee in 2025 Canadian Medical Hall of Fame. So congratulations on that. We expect, I think Fair Trial would be the first of your many books that we will be enlightened with, and very, very good wishes for your future endeavors, the research tracks you are going through, you are doing, and I can't express the gratitude. Thank you. How honored we are to have you in the conversation with Magazika. Thank you very much for being with us.
Well, I appreciate it. Thank
Thank
you
you.
very much for having me.
Thank you.